So the question is really, what are the challenges with ctDNA implementation versus tissue, and could it replace tissue? Well, the biggest challenge I think we have is that, at least in the UK, it's not funded. So we need to find a funding agency that's going to fund it, and that's generally the NHS. So we are working with the NHS England Genomics Unit to appraise our data, and also working with the NHS Genomics Unit to look at implementing ctDNA in an earlier time point in the patient journey. If a patient has a ctDNA NGS blood draw and analysis before a biopsy, at the time at which they have suspected advanced non-small cell lung cancer, we have pilot data to show that this can significantly shorten the time to treatment, even more so than before, and can really help in the decision making for patients with difficult biopsies and in patients with poor performance status with comorbidities. This is a transformation project which is being delivered through the Genomic Medicine Service Alliance's infrastructure within England, and I very much look forward to the implementation of that transformation program and the results, and working with NHS England for future delivery. Undoubtedly, ctDNA can potentially replace tissue, but not in everybody. And I think the fundamental problem that we have with ctDNA is, if it identifies a tier 1 driver, bingo, we found our target, we know what we're talking about. However, it misses patients with tier 1 drivers because not everybody sheds ctDNA. So it's quite hard and challenging to interpret a negative or wild-type ctDNA NGS reports. But if you do so and don't find a driver, those patients should clearly get tissue NGS. And doing that in a timely manner is a really important mechanism to figure out.